This is the Overreaction Podcast.
Uday, how are you?
How are you? Good, thank you.
Doing well. Thanks for jumping on. This should be fun.
Yeah, absolutely.
So, how's your week so far?
Is it Friday? No, it's still Tuesday, right?
It's Tuesday.
Yeah, I mean, weeks and weekends blend into one big thing. I don't even look at days anymore. I just look at like months.
So, do you see patients or on call or anything like that over the weekend?
Yeah, absolutely. I mean, I'm
Man,
by myself, and so I rarely get coverage unless I'm going out of town. So I'm seeing patients all the time. I just got done with clinic, actually.
oh wow.
Yeah.
And you're in Houston, right?
Yeah.
Awesome.
Yeah.
So let's just dive in. So, where are you from?
So I grew up in Ohio. I grew up in Cincinnati, and I went to I grew up there, and then I went to St. Louis. I went to Washington University for college,
Oh,
and then I
nice.
went back to Cincinnati for medical school. And they just got done with their match, the residency match, just I think about a week ago. So I matched in Houston at Baylor College of Medicine for internal medicine, and that was in '99. And I told him at the time my wife or my girlfriend, now my wife, but I said, yeah, we'll probably be here for a couple of years.
Yeah.
Now that's 25 to almost 26 years ago. So
Yeah, it's the same with us. I'm from Canada originally. My wife's from Canada, and we moved to Utah. Went to school here, got married. Never, ever thought I'd stay in Utah.
Right.
For sure thought I'd go somewhere else, but just fell in love with the mountains. And
where in Canada are you from?
Little tiny village about 2.5 hours south of Calgary called Sterling. Just tiny nowhere area. Great place to grow up. Great place to be from.
Right. Not necessarily go back.
No, yeah.
Go
back, vacation every once in a while, but it's too far from the mountains. So too cold, too many mosquitoes, all that stuff.
Oh, I'd kill to be where you are now.
It's pretty good. A lot of people are. In fact, I'm lighting candles for California just so people that stop coming here, they can go back to California. I want California to turn around. I'm very pro California.
Yeah. That's what I was. A lot of software companies are moving to like Utah, Idaho, this area, and they all say everyone from California is moving, and then also a lot of people from California are moving here to Texas too. So
a lot, like Austin specifically. Do you getting some over in Houston?
Yeah, I mean, Houston's blown up since I came here. I think because of the healthcare scene, that's one big reason. But it's just a easy place to raise a family. It's affordable, relatively, and it's a great place to start business. So I mean, Texas is blowing up. It's not stopping.
That's awesome. What part of Houston?
I mean, I live in Katy, but I practice in the medical center. So like we have this huge medical center, Texas Medical Center, and so I practice mainly there. But I mean, I'm all over the city because I have satellite clinics in different places. I have another satellite clinic near Waco, not far. It's a small town outside of Waco called Groesbeck, Texas. So, I mean, my car puts on the miles. So we drive around a lot.
Man, I bet.
Yeah.
So what made you, when you're medical school, what made you decide near the end to get into nephrology? Like, what was it that attracted you?
I mean, I liked analytic topic, analytic fields. I like math. I liked chemistry, and that's what I really wanted to kind of get into. And I just thought that of all the fields, nephrology kind of hits on all those points. And so I knew pretty early on my intern year that this was what I wanted to do, and I just focused on becoming, just going into nephrology and just kind of focusing on that. So it's mainly the science behind it. I really wanted to go into a career in research. It just didn't work out that way. But from an analytic standpoint, nephrology is the best.
That's awesome. Do you see a shortage of clinicians that specialize, or you're seeing that there's more than enough clinicians?
I mean, we're in Houston, so there's more nephrologists than Starbucks. So, it's I don't see this short. Everyone talks about a shortage of clinicians.
Yeah.
I don't see it.
Yeah.
We're used to, like, we trained at a time when you're used to seeing a huge census of patients. And so I think it's a different day now. So then maybe people feel like they shouldn't have to see as many. And so then they recruit more doctors to fill the work. But I don't see the shortage here. Now I can understand when I go into rural areas, there's obviously a big shortage. For the smaller towns in Texas, there's obviously a shortage. I'm not seeing it here. I don't see anything in Houston that requires an emergency influx of any specialty. Not here.
Yeah. That wow, I didn't think that. You just hear, you get so many rumors and there's so much stuff out there. You got to dig through. I guess one of the words of the day is misinformation that gets promulgated.
When people say there's a shortage of, I guess there's a difference between number of physicians and access. And I'm not saying the access is great, but there's a lot of, there's so many, like, I think there's double-digit nephrologists just at the few hospitals that I work at. So it's, there's a lot of doctors. So I don't understand.
How do you differentiate with that number of doctors? It's very competitive. What's key for differentiation then?
Well, the thing is that, everything's changing now. So you have more doctors, nephrologists included, that are employed by hospital systems. You've now gotten some of the bigger groups getting bought out or kind of sucked in by the private equity groups.
Of course.
Right? That's like the big thing now. And so I think what ends up differentiating any doctor, specialist or not, is at the end, it's a customer service deal. And its ability to provide, it's an ability for have patients have access to their doctor. I think that's what it just comes down to. Of course, being here for 25 years, I've built a lot of relationships, so that's helpful. And we've built our networks, and that network, you build those networks, that becomes a way of keeping afloat. Then it just becomes a game of how do you differentiate yourself amongst the other doctors.
So do you find yourself, like, when it comes like referral patterns, you find, how do you dance the line between working with the referring organization, referring providers, but then actually kind of marketing directly to the consumers themselves, the patients?
I think you can do both. I think that you can still have your network of doctors that refer to you and still at the same time try to direct. I think the best way to direct market to patients is to educate them that, hey, this might be something that you might want to look at. So, sometimes we do health fairs, our website, you try to educate people like, hey, if you've got swelling in the legs, you might have a kidney problem. And so I get a bunch of people in my clinic that are like, hey, I noticed, I read somewhere that if you have swelling in your ankles, that could be a kidney problem. Can you help me out? And that becomes a referral.
Yeah.
So you can do both. I don't think it's one or the other.
That makes sense. It was interesting. I was talking to this is out in Columbus, Georgia, I think, before they started. It's called the Diabetes Studio, Reach 7. And so it's interesting, the background of them. I think, actually, I had the founder of it. He was early on one of my podcasts, and they'd come up with this solution for clinics. I can't even remember what it was. And they've been running it for years, and they could show, hey, if the clinicians adopted this, whatever it was, it actually helped treat patients better. There are better outcomes. What he said is the hesitancy from clinicians to want to change how they behaved at all. Their workflows, the pushback was so significant year after year. And those that would do it, they had happier patients, and their clinicians were actually more satisfied in their job. He said, but it was so hard to help them see that they should do some adaptation. So So like I raised money, decided I'm starting my own. It's easier for me to start a diabetes studio than continue to sell the software.
Yeah, I mean, I'm a doctor, but we're impossible.
What do you mean?
We're impossible to work with, and because we have our habit.
Yeah.
People, if you've been doing this even if you've been only practicing for like say 5 years, you've still been doing it for another minimum 5, because of training.
True.
And your perspective is always going to be kind of set that way. And, we're not the most flexible community. And so I don't blame him. So that's one of the things that, for me, it's kind of like, instead of trying to manage, I figured I'd just rather build my own multi-specialty group and implement the things that I want internally, as opposed to trying to convince someone else in order, to adopt customer service friendly models and getting reviews and marketing and things of that nature. It's just that it's just very difficult. People don't want to. I mean, we're the only people on the planet that still use a fax machine, I think. So there's a reason for that, right? We don't like changes.
That's funny and not funny, but
yeah, it's not. It's awful. It's the biggest headache. But
so let's talk about so the multi-specialty, that's Remix Medical, right?
Mm-hmm.
Okay. So when did you start that, and go in more detail, if you wouldn't mind, on why you started it?
So I was one of the co-founders of another practice, and we went our separate ways at the beginning of 2018. And my thought was, I wanted to be able to close the loop on patient care. The second stuff starts leaking out too much, you're responsible for the patient, but at the same time, you can't control like what's happening outside of your own practice. Yeah. And I thought, from a business standpoint, but also like where I thought medicine was going to go, that I really believe that practices were going to start not just being single specialty, but they were going to start working and integrating in a way where they found common synergy. I thought from a business standpoint, it made a lot of sense. And I thought from a patient care standpoint, it made a whole lot of sense. And so in 2018, we just started forming this Remix Medical, is a multi-specialty group, and we had like internist, nephrologist, and a pain specialist. And then we've slowly moved up, and we've gotten family practice. We've gotten a pulmonologist. We're slowly growing it in order to really close the loop on the care for patients. But it's also helps us expand into more areas, and it brings more like a better variety of different types of business opportunities for us too. So it was both for business and for patient care.
That's great. And consistently growing, it sounds like.
Yeah, I mean, I intentionally didn't try to make it bigger. I thought the thing that was, I think it's not hard to make a group go from 1 to 5 to 10 to 20, but can you support that group? Mm-hmm. And so we've spent a lot of time on just like things like internal communications, and like, how do we make it so that we're actually providing a good service to the patients, not medically speaking necessarily, but the experience. Like, the experience is what really, to me, matters, because providing the medical care, you just need to make sure you have good doctors around you, but everything else is what really makes a patient happy and content and want to send their own family back to you. So we spent a lot of time just trying to get that sorted out and just get our infrastructure sorted out. And now we're in another phase where we're going to start growing this and trying to get more people to join, and just expand geographically and just build a big network. So
same types of services, but adding more locations, or also adding more services?
More services. So we had recently we just brought on a wound care specialist. And so, but I would love to get more internists and primary care doctors. I think that's obviously going to be very important for what we try to do. And then you take that model and you can expand geographically. And I really want to try expanding into more rural settings.
Oh, yeah.
Because I think some of these areas have a lack of specialists. But if you're all in part of a single network, you can find a way to make that a little bit more feasible. So you don't have to recruit specialty. You can go in as kind of like a gang, as a group. And so that's kind of what we're trying to do and look at, how we're trying to grow.
And what kind of like payer mix or patient mix is ideal?
I mean, I'm not sure about ideal, but in general, we see a lot of patients with Medicare or managed Medicare. So that's the bulk. And then we have patients with private commercial insurance, and we have a decent number of patients with Medicaid or commercial Medicaid. We have some patients who are cash based. So we really don't we don't spend too much time focusing on that.
Gotcha. Do you have you felt any sort of tug to go to kind of that concierge model?
No, I mean, you see it on LinkedIn, and you see it out there where people want to do the the DPC model, and good for the people who are doing that. That's great. I mean, I think it's fantastic, and I see the point that they're making, because the problem is that it's really, really hard, and we spend a lot of resources just getting through that insurance red tape. It's a lot of our overhead is just based on that. But the reality of the situation is that, for instance, in nephrology, it'd be very difficult to do a direct, to do that DPC model with nephrology.
That's true.
With hemodialysis or any dialysis and kidney transplant, people aren't going to pay for that out of pocket.
Yeah.
Yeah,
no, that makes sense. Do you see, I don't I love getting into politics over private discussions. I don't like it.
I don't mind. I don't hesitate. I give my opinion.
So do you see any hope with kind of the current administration that some of this red tape can get kind of carved? Because that's kind of for good or for bad, whatever side of the aisle people are on. That certainly is a big topic right now, is trying to eliminate waste, red tape, whatever. And I remain skeptical that much change can happen, just because of the sheer gravity that exists to push against any kind of change. So I'm a little skeptical that much is going to happen. That's just my opinion.
I mean, I think regardless of political affiliation, I think one thing, and there was an article today in one of the online journals where they were talking about how the current administration wants to find a way to help promote new treatments, new research, new technologies, and try to get rid of the red tape to get treatments more to patients, something to that effect. And I think that there is some bipartisan support on basically trying to help independent practices kind of stay afloat. Now, I know people say that, but then the reality of the bills that they pass could be completely different.
Exactly.
Right. I think that in some ways, staying where we were before was not going to be beneficial to us. Was not going to be good for us. Because I think that there's a heavy push towards the corporatization of medicine, and that needs to be shattered.
Yeah.
Healthcare, if it keeps going down that route, it's going to just continue to be crippled. There needs to be more independent physicians. There need to be more independent physician groups. That's, to me, where the answer is for the future of healthcare, if we want to get an improvement. And so from an administration standpoint, I mean, who knows? Every day I turn on the news and something crazy is happening. But I'll say that I think that there's more and more push towards, maybe questioning the old ways that we've been doing things, and that needs to be there.
Yeah,
I mean, I don't.
100%. It's so one thing you said earlier is I try to avoid sound bites. Like I don't. A couple of years ago, I quit watching debates. I'm like, I don't care how well someone debates or the sound bites. I like to read what they're saying. I don't want the emotion attached to it. I'm not trying to get caught up in charisma one way or the other. And then same thing when it comes to like laws. So that's one of the greatest things about ChatGPT or Grok. Like we use it a lot now on like legal contracts. Like tell us what are we liable for? I don't have to pay lawyers $600 an hour just to go review if ChatGPT can go tell me that.
Absolutely.
But it's also synthesizing, saying, hey, here's this 72-page ridiculous thing the state of Utah is trying to do. I can copy the file, upload it in ChatGPT and say, summarize this for me. Give me what this says, because I don't care what a regulator or a politician says. I'm done. I don't care about reading the press release. I don't care about reading some article about it. I want the source material. Give me the source material, then I put it in, and then I come away and say, "You lying sack of." That's not what you
promised. Yeah.
Exactly. This is what you said. And there's these couple paragraphs that deal with it, but then there's all this other kind of stuff that you're trying to slide past me on the sly. And so that doesn't, I always go back. It's a law of unintended consequences. It's we got to put meaningful use legislation, and we got to put the High Tech Act. We got to make everybody do EHRs. Like, okay, well, cool. We got EHRs everywhere. We spend tens of billions of dollars. Wow, a doctor's happier? No. Or nurses happier? No. Or patients healthier, happier? No. Well, what do we just
Why we do all this?
All the data is digital. I'm like, I'm pretty sure we could have done it in a cheaper way than that.
But in some ways, that's where I become very kind of militant. Like, I just don't believe that there has to be a lead role in non-physicians in healthcare. Like, you need non-physicians in healthcare, obviously.
Sure.
But you know how awful it is when I'll go to a hospital floor and I'll see some patients and I'll want to write a note on the computer, and all those computers are taken up by suits. They're taken up by some administrator or some case manager. Or some,
yeah.
And so I'll just go home and do my note there. I'll go to my office and I'll do my note there. But that's because it's been overrun by bureaucracy. And I'm sure, of course, rules are great. But, when you talk about physician burnout and all these things, people like to point to the EHR because we have to type. But it's not the typing. I mean, we used to work in much crazier conditions when we were training. It's not that. It's the constant nonsense from administration or from someone or like an insurance company making you do a weird peer-to-peer or prior auth or whatever. It's that kind of thing. It's the corporate aspect of healthcare that's really making doctors just want to leave the profession, because it's just and that's kind of that's a shame. And I think that's why I think when you talk about politics, if I want to have a clear, and I'm a hothead, but if I try to focus on the stuff that's being talked about, I really want to see legislation that, and I don't care if it's partisan or bipartisan or whatever, that focuses on strengthening independent practices, independent doctors. Let doctors own their hospitals. I mean, the idea that a doctor can't own their hospital is total insanity to me.
Yeah, there's some guys there's some physicians I follow on X where they hammer on that constantly.
Yeah,
and they're totally right. In fact, I got to pull up. Keep going on this. I love it. I need to pull up a slide to send to Matea to load up here.
Just
what you're talking about.
Doctors own a hospital. They'll, unnecessarily refer patients to that hospital or whatever. And I'm thinking, so therefore you have to get some administrator making $500,000 a year to supervise those doctors. I mean, the waste is in them. It's not in what we do. So I just think that the reasoning behind it is just awful. And, it takes us out of the loop of managing patients. It's already hard. I mean, they make it harder. And so I don't want to go out and own a hospital. I don't have that kind of money, but just the idea that we're being kind of shut out of that is bizarre to me. It's bizarre to a lot of doctors. Certificate of need. Thankfully, we don't live in a certificate of need state, but it's so anti-competitive. It's such anti-competition, And so I look at politically, I look at stuff like that. And I try to keep an open mind on who's delivering it.
Yeah, as you should. I don't know if you've seen some of the stuff I put up on LinkedIn, where I'm always I like AI. I have a software company that uses AI, that kind of stuff. I think it's kind of a little bit overblown. But there's all this, AI is going to save healthcare. AI is going to save healthcare. I'm like, you know what? AI can help with the current crap that goes on, the insane bureaucracy can help with a little bit, but the problem healthcare needs to be looked at and saying, look at all this insane inefficiency, massive amounts of red tape, just blocking everybody. AI can't change that.
Yeah,
it can put lipstick on that pig, but it's still a pig at the end of the day.
Absolutely. The funny thing is, I think that if you look at with the concept of AI, I totally agree with you, because if you unleashed like a full blown we can do whatever we want with AI type of thing in a hospital, the administrators would use it to get rid of the doctors. It should be the other way around. You should be able to use AI to get rid of the oversight and the management, not get rid of the people making the clinical decisions that spent decades training to do that. But that's where we are right now. So it's funny how doctors are all like, oh, AI is we're not going to need pathologists anymore. We're not going to need cardiologists. But I never heard a hospital administrator saying, oh my God, AI is going to make me lose my job. It's because it's rooted, it's this corporate, stranglehold on healthcare it's a menace. And so I don't know, that's like one of my big things. Like, we don't want to go out and sell out to private equity. None of us are looking to do that stuff. I mean, we'll do business deals, but we don't want to work for, we don't want to work for suits. Nothing good happens. Totally. I've never heard of someone selling to private equity and saying, my life is so much better.
Have you been approached by private equity?
Not really. I think that I don't know how many people are going after like these kind of multi-specialty groups. I mean, as a nephrologist, I have, but not for like, a group of, multiple specialists. Yeah, this is exactly it.
Yeah, this is it. I mean, this is what bothers. Yeah, I'm a libertarian, which is probably going to annoy a lot of people that are listening. I look at all the areas where we keep spending money. So the money doesn't matter what it is. The money. But then you look at the amount of money that actually makes it to the people that are actually doing the work, or to the people that they're serving. Regardless, I don't care if it's obviously in healthcare, it's rampant. In education, it's rampant, et cetera. You're just like, the costs are going like this, but the benefits and the value isn't. So you have this pretty much flatlining of physicians and nurses. I'm sure if they overlaid it was similar, but the industry has gone through the roof. You're like, we need AI just to cut this out. Like, how do you and I put this the other day, like, McKinsey, of course, put out some article and said, now's the time for a chief AI officer.
Yeah.
No, it isn't.
Yeah.
Like, no, you already have a CIO. We don't need a CIO and a chief digital officer and a chief transformation officer. Your CIO, anything IT related. Yeah. One person is on the executive team.
Yeah.
They can have directors under them that are, this person's the AI expert, this person's digital transformation, well, that's fine, right? You need to have your people, but how many different C-levels, how big do you have to make your conference rooms?
Well, the thing is, when you given unlimited power and you're able to wipe out your competition so easily, then you can then there is no limit to the number of C-suite people. In fact, you might as well spend hundreds of millions of dollars on new buildings just to house those C-suite people and become this big, group. The fact that it's gotten to this point, it's not going to stop unless there's like true reform, and the reform has to be here. It's not in, should we let doctors accept a $5 pin from a drug rep, or force feeding people to report on certain parameters, forcing doctors to report on certain parameters from the clinical note, and then doing all sorts of crazy stuff with the billing codes, and then all while cutting their payment every year after year after year. It's in this thing. It's in this big blue smear. But they'll gaslight you into thinking that it's in the yellow.
Oh, of course.
Right? It's that yellow that's crippling. And the funny thing is, a lot of patients think that too. They think, oh, you guys are rich doctors. It's like, oh, you're a rich doctor, or when you're playing golf. And it's like, if they saw this and they understood this picture, they would get it.
Yeah, it's the same thing with education.
Mm-hmm.
It's how many. So my wife helped start a charter school,
mm-hmm.
and it was part of that reason. It's like some bad stuff happened with one of our kids, and we're not one of those parents that just believe our kids. In fact, most of the time we would believe the teacher instead of the kid. That's just the way we are. It's like, what'd you do? But in this case, it wasn't that. And the level of different people that was around that teacher, and they had to talk to, and I started looking at it, and my wife's way smarter and more aggressive than me on this kind of thing. She said, this is just insane to get anything done. So you start looking at it like, here is the number of kids and the teachers. And then you start looking at across just the school at the number of people that are not teachers or educators or support staff to the teachers or the students at all. And it was like, there's more people that have nothing to do with actually helping the students than otherwise. And same thing in healthcare, like the number of just nurses and physicians and respiratory techs and med techs and, CT techs or whatever are dwarfed
mm-hmm.
by people that have nothing to do with what's truly going on with patient care.
Yeah.
And that's what you go after.
Yeah, absolutely. Right? It's a no-brainer. And the thing is that if you just look at this, look how steep it is. And then look at the context of people saying how much money we spend more than other countries on healthcare and stuff like that.
Yeah.
And this is outrageous. And you're right. Education is probably another. So this to me is the biggest problem we have, is this idea that healthcare can be, taken over by corporations, and patients and society is going to be happy about that.
Yeah, and it's so interesting too. I remember I was getting interviewed for this was back in like 2011, and I was just getting some publication in healthcare, and they're saying, okay, who do you worry about the most? I'm like, well, what do you mean by worry? So who concerns you, right? Is it Apple coming into healthcare? Is it Microsoft or whatever? And I said, no, actually, the one that concerns me the most is actually UHG. They're like, well, what do you mean? So the United Health Group controls everything.
Mm-hmm.
They're buying like practices.
Yeah.
And they're buying doctors and nurses. And back in 2011, they were way, way, way smaller. Now I'm pretty sure more physicians and nurses work for United Health Group than even HCA or any, the biggest of the biggest health systems. And I'm like, that seems really concerning to me. And it's almost like the old factory or the mining town where the coal mine company
mm-hmm.
owned the restaurants and owned the stores and owned the doctor's offices and clinics for, in West Virginia in the coal country. They controlled literally everything.
Yeah.
They're integrated from top to bottom and side to side. So no one in the town had any leverage. They couldn't go anywhere else. They basically had to take whatever's coming. That was my concern with this consolidation that is happening.
It's a good.
It is definitely worse for the consumer, and it's certainly worse for the physician.
I mean, that whole Change Healthcare hack. I'm sure you followed that.
Yeah.
That, if I'm not mistaken, weren't practices that got crippled by that hack get bought out by some practices get bought out by UHG?
I think that's what happened with some of them.
And the ironic thing is they own Change. So it's unbelievable.
It's so funny. It's like whoever controls it, the FTC or whatever, blocked Adobe from buying Figma, just that visualization thing, right? And it's like, I didn't know that Was that a big deal? Like, is that like a super, there's only like a couple different data visualization, flow chart things? I'm pretty sure
UHG can
Microsoft has
buy
Visio.
everyone, right? And CVS and Walgreens can buy.
Yeah, but that's my point. But in healthcare, you're having these things where the roll up, and in certain areas, you don't have many insurance companies that actually can compete. That you get a certain different health systems end up dominating.
Yeah.
The area. Rural facilities would like to stay independent. I remember I've talked to a couple of rural facilities. They're like, here's the issue. We want to try to do anything we can to stay independent, because as we talk to our friends out there that are in other rural areas and they get bought by bigger, the services get worse. They don't get better. It becomes far less personalized, and they don't understand. You can't practice medicine in rural locations like you can in urban settings. It's radically different, but they don't care. Like, nope, this is what we're doing. Private equity bought us all, roll it up. Here's what you got to do. We're going to force the same things and the same processes and workflows to happen everywhere. And like, that doesn't work.
It doesn't work that way. I mean, I work in a rural area, and the approach is completely different on how you have to deal with things. And I always used to use this concept that healthcare is a local thing. So like that one big urban hospital that in the center of the city, that's great, but like more and more people want healthcare in their communities. It's like a community thing, just like schools. It's a community thing. It's 100% like that. And when you start, when you start trying to corporatize that, like different varying communities, people with different backgrounds, economics, needs, it's not going to work well. It's not going to work well. It may have a pretty package on it. They may have some nice places with nice lobbies, but I don't think you're going to have a more satisfied public. So I just don't think that. People don't want that anymore. People don't want McDonald's or Chipotle or whatever. They want something unique.
I want to dive, frankly.
For that. People they'll go the extra mile just to get something that makes them feel like they're not part of like a big assembly line in anything, food, healthcare, everything. So,
well, to your point, the relationship is everything. I mean, the doctor-patient relationship, the relationship between the clinician and the consumer and that location, it is more like a B2B relationship. But unfortunately, it's treated more like, just mass B2C, like McDonald's. They do their brand research and customer research. They don't really care at all. Like, what does the person think about to the local McDonald's? And again, I don't go to McDonald's much. Mm-hmm. I may be wrong about this, but they care more about just the brand perception.
Yeah.
But that isn't how it is when it comes to clinical care. It's, you have to trust this person. This really, especially if anything's remotely chronic.
Right.
No, this is an ongoing relationship between this specific location and these specific people. So quit trying to make it transactionally based, and it's not. And so much of what I see is everyone tries to look at it from a transactional perspective rather than, no, this isn't, you want to foster an ongoing relationship. And how do you do that? Well, you've got to meet them where they are. You've got to understand what's really unique to them, rather than, like you're saying, this conveyor belt commoditization that's trying to be pushed everywhere.
But they sell it that way, right? They sell it like, you'll have these huge hospital systems with billboards out there saying, we provide personalized care. Like, you guys, every room looks the same. Everything, every from A to Z, everything is exactly the same. There's like, personalized is the least of what you guys do. And so, but they sell it that way.
Yeah.
We provide personalized care. And then the patient's like, oh, okay, I guess they provide personalized care. They're better. But when you cripple your competition with just unfair practice, like, with hospitals, hospital-owned outpatient clinics can bill much more per visit than, say, a private doctor that's not affiliated with the hospital. Exactly. That's a highly anti-competitive move. So how is that practice supposed to stay open? And so now there's no choice. Then therefore there's no real incentive to providing personalized care anymore, because you You don't need to. You don't need to be better. So the whole system is, because of this, that trickles down to every aspect of the healthcare system. But you're right. And that's why we also did the multi-specialty thing, is because patients want their doctors and their healthcare system to communicate with each other and to be like network and to like work as a team. They always say to us, can you work as a team? Work as a team here. I need help, instead of being ping pong between 10 different doctors, and 10 different buildings. And so I think that's one of the reasons we created this group, is because I think that model is what people want. They don't come out and say it, but they want that. That's my bet. I think you're going to see more practices do stuff like that.
Oh, I think you're right. I think your model is spot on. I think it's going to continue to grow. And I also like too, because I noticed like on your site, you use AI, I think the right kind of way, where you're just trying to, things that take quick interactions.
Yeah.
AI is great. My concern, and I put some posts out about it, is these organizations that are either lazy or just too tired to do it the right way. And they're trying to replace as much interaction with a patient that should be more with live people. And they just want to try to handle more and more of it. I'm like, no, to me, AI is great for automating away a lot of garbage internally to free up staff, physicians and nurses, to actually get more time to actually spend with the patient. Because if I wouldn't feel good if I'm still getting only this limited amount of time with a doctor, with a physician and their staff, but I'm now having to interact with AI, and I feel like I'm being passed off. Like I'm even less important now. And
that's the danger of the whole thing.
Yeah.
And I mean, to me, this is a people business. So one of the things, right? It's a people business.
Yes.
And one of the things that we do is, we did increase our number of staff. So we use a lot of homegrown virtual assistants because we want our phones picked up. So the biggest complaint people always used to have is no one picks up the phones. At any practice, you call a medical practice, no one's going to pick up the phones. Yeah. Now AI is picking up the phone, but people know, and it's not, I don't think they like that. I want humans talking to humans. I'm not saying I'm anti-technology. I love technology. It's just that's not where you use your AI. You use your AI on back-end stuff, like make sure that the paperwork you have gets sorted out correctly, and make sure your revenue cycle platform is acting in a way that's efficient and things of that nature. But for people who are sick, they want to be able to speak to people who understand and have some degree of empathy. And I'm sure one day AI will have empathy and all that. That's great, but it's still not the same.
I totally agree. Like the technology is there to automate the mundane as much as possible.
Yeah.
And especially in a people business, it's like the whole rest of the business, we're going to use technology as much as we possibly can to become as efficient as possible.
Yes.
So that it will create the best environment and relationship between us and our patients and improve their outcome, not so that I don't have to talk to them anymore.
Yeah. One of the things that I like AI for is the conversation in the room, right? So it used to be that we'd try to find weird ways of like being able to type on the computer and talk to the patient and do and no matter what, it's awkward. And so what I like now is this conversational AI with our like EMR, where you just click a button and it records everything, and you can sit there and talk like two people talking. And I think
do you use a bridge, or who do you use
for our AI tool?
Yeah,
it's built into eClinical Works. It's called
okay.
Great. And do I love it? No. Has it made my life a whole lot easier? Yeah, it has. Like, it's better than having a scribe.
For sure.
And I can go over my notes later on if I want to go through stuff, and it does a pretty good comprehensive. And I still put in I do my portion to make sure that it's, authentic. That to me is what, as far as I'm kind of willing to go. Maybe some of the front end phone system, or we have a web chat thing. Like if people want to know what the fax is or whatever, of
course.
But not like I'm having chest pain and then the AI tool is going through some algorithm that was fed to it. That's not what you need.
And you're not charging for text messaging like Epic does.
No, you have to increase access. So that thing was hilarious to me when people were like charging for my chart messages. I mean, if my doctor charged me for a my chart message, I'd strangle him.
Yeah,
That's these people are sick and they have
exactly.
questions, and sometimes you can't remember especially if you're stressed out, you can't remember your question in a 10-minute visit, 5-minute, whatever it is, and then to get charged extra after waiting in the lobby for like 90 minutes. Oh, I think that's ridiculous. Like, we spend more money. It's not we pass the cost on to anyone. You can't. We spend more money on communication with the patient because it makes everyone's life better. The patient's life better. It makes it easier to manage them between visits. Like, healthcare isn't the visit where the patient comes and sees you. Healthcare is all the stuff that happens between the two visits. It's not the bookend. It's the book in between. And the only way you can actually get anything is if you have communication with your patient that's free and easy. And so we let patients communicate with us in any way they want. Sometimes they walk in and say, "Can I see the doctor?" And if we're here, we'll do that, because it makes managing their medical issues so much better, and it looks, it's good for them. That's what we signed up for. Not charging people for an email. We're not lawyers.
Yeah.
charge on 5-minute increments or
I
whatever.
know, man. Well, you talk to them for 5 minutes, they bill you for 15. They round up like nobody's business. But I mean, nothing tells one of your patients that they're absolutely not a customer, that in some ways you're the customer, that they're being charged even more. They're already scared about things, they're already nervous about things. And then it's like, they're limiting. They're like, oh, I can't, I do have a question. I don't want to get charged for it. So they don't.
Yeah.
They don't reach out. You don't want that. You don't want anything that says, no. Let's make sure the patients don't ask us any questions. We want to increase as much friction as possible between our staff and our patients.
They have to break that barrier, has to be broken down. And see, that's the thing, that's why I feel really good about independent medicine. Like, I know independent practices are shrinking and independent doctors are going down, but I feel good about it because we're better at that than corporations are. We're better at dealing with people than corporations are, because we don't have 50 layers of bureaucrats trying to sift through a simple question. We don't have someone out there coming up with a great idea of charging people for my chart messages. So, and so that's why I think we can do it better than they can. They know that too. That's why it's stacked so much against us. It's because if we were allowed to work on an even playing field, they'd be toast. Because I think a group of doctors, nurse practitioners can come up with a much better system. That's the quality that provides the patients what they really want, our community what they really want.
For sure. Well, that's one of the things too. When I've looked at regulations that come out from the federal government, I try to backtrack and go reverse engineer who's benefiting from it. And it's rarely the small independent companies or clinics or hospitals. It just isn't. It seems to constantly benefit the incumbents.
Yeah.
The ladder's always being pulled up. I mean, why shouldn't there be way more specialty hospitals? You look at the overall costs go down, the quality of care goes up, the level of infection goes down, but they're blocked. Yeah. You can't have an orthopedic hospital. Well, we can only have so many in the state, or some heart hospitals,
right?
Or, cancer hospitals, or, specialty clinics like you have. No, we need to bring it back into the community hospitals because they're at risk. They're going to lose these high value patients.
Mm-hmm.
Yeah, there's nothing better than mixing a bunch of chronic disease patients with surgical patients.
Yeah,
makes total sense, right? You should lump them all together. In fact, we should do more Petri action. And so just physician-owned practices, physician-owned hospitals should be the standard of what everybody should model. But it's constantly
I think so.
blocked.
I mean, and the thing is that, or at the very least, don't let them make multipliers more for the same work as compared to the non-hospital affiliated doctor. I mean, it's absolutely crazy. And I think if people really saw that, they would understand that, they'd understand kind of what's going on there. they're being pushed towards the big hospital systems, and they don't want to go there. I've never seen anyone say, "Oh, my stay in the ER at this big hospital was so awesome." No one ever says that. They always say,
everybody tries to avoid the hospital.
Yeah.
If they can. They're like, no, I want to. It's like when I do a lot of mountain biking and I'm all broken up. I'll do anything I can just to get to an urgent care.
Yeah.
Like no way in the world, because the times I go to the ER is absolutely the worst. And if I get admitted, I'm like anything I can do to avoid going to the hospital.
Right. So I don't know. I just think that everything is upside down when it comes to healthcare, and I just have that focus on that. That corporate setting is really, really what's doing it. It's just destroying choice. The public doesn't get a choice in what they could get. It makes it just, I don't know. It's not where I think that healthcare should be.
I agree. And hopefully it's going to change. I was talking to this lady, she's in Silicon Valley, and she's like, I didn't vote for the current administration. Goes, but honestly, I don't have as much fear as other people. It's like, how could it get worse? Like,
yeah, that was
that's what she said. She's like, how is it going to get worse? Like, we're headed towards bankruptcy as a country. Like, we're worried about Medicare getting funded, like all this kind of stuff. We're just freaking out about. We've been talking about. She's like, I don't know, maybe it gets worse, but I don't know how it gets worse. Like, got to try something different. I guess.
I mean, for the things that matter to me professionally, it's not like the Democrats were saying something that was more in line to what I was thinking. Really, no one is. No one is saying we got to get corporations out of healthcare. Now, who says that? No one.
No. So
from a professional standpoint, I mean, I had my personal preferences or whatever, but from a professional standpoint, I didn't see anything there that made me feel great either way. And so, because I think that people are missing the boat. I think there's too many people equate hospitals and being super sick to healthcare, and I just don't think that's what healthcare is. I think healthcare is not that situation. Those are urgent situations where something needs to be urgently fixed, but that doesn't mean you use that model to take care of a whole public or build a public health policy around. So I don't know. I'm hopeful that we have something gets put together where we can start taking health, like medicine, back.
Yeah, amen. That would be great. We only got a couple of minutes left. Anything else we should discuss that we didn't get into? That
I hope we got into what you thought would be.
No, we did. No, this was fantastic. I mean, we talked before. I'm super focused on. I put so many things out. I'm always talking about. Healthcare organizations need to see their patients as customers. They can't see them as these. There are a lot of organizations. They almost see patients as inconveniences, which is odd. And what attracted me to wanting to do more calls with you, Uday, was your focus on there's all this chaos and issues and inefficiencies in healthcare, but we're going to try to protect the patient from having to experience this stuff.
Yeah,
focus on treating them as a customer is because the next generation, the younger millennials and Gen Z, they will not put up with a Gen Xer like you or I put up with.
Right.
They will absolutely not put up with it. So it's like healthcare organizations, you'd better start understanding the relationship is king/queen. If you don't, you're going to be in real trouble.
Well, let me ask you your opinion. How do you feel about retail, like, the retail healthcare systems like Village, or, there was which one's in Walmart, these doctor clinics popping up in pharmacies. And
I love the concept just from a convenience perspective, but the problem is they didn't understand provider medicine.
Mm-hmm.
So that's from a contextual perspective, I looked at Walmart Health and I went, you look at the patient population of Walmart, the average consumer of Walmart, there's the people of Walmart memes that go around.
Right.
So I'd say, they're going to need care more than your average Joe Blow, Joe Sixpack, or whatever. They already have this real estate, right? They have these big parking lots. They're really well lit. I could see having a medical center there. But the problem is, rather than operating as a completely independent, separate unit, they get kind of subsumed into the retail which doesn't work, because Walmart itself is a transactional B2C relationship. Healthcare is much more B2B. So there's like the convenience perspective. If Walmart could have said, is there a way to bring the convenience and the communication that we do like in retail? But outside of that, we can't F around too much with it. They couldn't. So Village couldn't figure it out. Walgreens couldn't figure it. CVS, they can't figure that out.
Yeah, I thought that was that's
just my 2 cents.
I agree. I just think it's, I totally agree. Like when these places started popping up and then the billions of dollars that, every day there was like a big $1 billion infusion to one of these.
Oh, so much.
And I just didn't get it. We get a lot of people that leave those setups and come to us. I just don't think that people want to, like, I like hot dogs, right? If I go to the baseball game, but
sure,
but I don't go to IKEA to get a hot dog just because they happen to have it in the in the basement or whatever. It's just not, to me. It just didn't fit. It didn't feel right, and so I was just wondering what people's thoughts were on it, because I was always very much, I wasn't mesmerized by the billions of dollars going through. I was kind of shocked. I didn't think it was going to crumble this fast, but
I didn't either. Like I put out posts in favor of it, but it was always a caveat. So I hope it works out, just because the things are just crappy so bad in a lot of areas of healthcare.
Yeah.
For me, it was just a convenience. Like if they could act more like a real estate investment trust and just saying, hey, we're going to put this in new Walmart, new Costco, new whatever. We're going to have this other section separated from it. It's not going to be part of the Costco, but hey, we already have these really well-lit areas. There's tons of people coming. It's super convenient. So we're going to leverage that, but they're going to run their practice however they need to. We don't need to, but we already have all this big infrastructure here, the power, the lighting, blah, blah, blah. It helped these independent practices come in and get started much, much faster and be more efficient for them and more cost effective. And it's just great. And then maybe there's anyone who's a Costco member, gets, I don't know, some little tiny discount for something. It just kind of helps with the transition. So it helps the referral patterns over to that's the only thing. That's what I was kind of hoping was happen. They couldn't leave well enough alone.
Yeah.
They mucked in the business that just destroyed it.
Yeah, I just think that one lesson we need to learn is the typical business things that make certain businesses flourish won't necessarily extrapolate into healthcare. I just think it's a different animal, right?
That's exactly it.
We can't run it like a software company. We can't run it like a retail company. It's just a different beast.
Well, it's utterly unique.
Yeah.
Healthcare is utterly unique. And so instead of looking at it and saying, how are we similar to a consumer-based business? It's in these areas, this part of the Venn diagram. How are we similar to a B2B company? Right? Here's the overlap, but then there's this other nuance here that isn't, and saying, hey, that intersection there, that's unique, that's healthcare. We can't mess with that. We have to, how do we make that better in that intersection? They can't. It's, well, I come from this B2C space, retail, so we know, and we're going to push that far. And they always go past the Laffer curve of it. Just okay, great, stop, whoa. They can't stop. They can't help themselves. Yeah. Private equity firms, for the most part, can't help themselves. It's like if I was a private equity firm, and I think there is one really good one that I've talked to before, Ziegler, that seems to be really, really good, where they seem to step back and say, we're investing because you're great. If you need help, let us know. We have some recommendations, but we're not going to tell you how to run your practice. So they're from what I've seen, for a couple, because I've talked to two different physician owners that allowed Ziegler to get in. They're like, yeah, it's pretty good. They didn't, they looked at some things we were doing that were really like, hey, you're way overspending for this. Let us help negotiate that for you. Right. We're not going to take it away. We're just going to negotiate better rates for you, better this. get your mortgage better, your lease. That's fantastic. So if I was that private equity firm, I'd say we want to go in, and our goal is to get rid of that stupid fat. We want the doctors and nurses to make more money.
Mm-hmm.
We want the experience for the patient to be better, but we can't charge a bunch more. We can't do that. Well, what do we need to do? We've circled this massive area of waste that is not helping literally anybody. It's extracting the value that's going to something else. What do we need to do? But the problem is that most private equity people don't understand healthcare either. They just look at the inefficiencies and go, well, I'm going to stamp that out. Like, whoa, easy there, killer.
You just turn the electricity off, basically. You suck the energy out sometimes by doing that. But no, I totally agree with you. I just think that it would be nice to be, look, if it's a successful practice that's being purchased, then let the practice do what it does well. And then just help them kind of remove the inefficiencies that are kind of impeding it, or, creating some inertia. That's all. That'd be ideal in that setting. That's not for me, but in that setting, that'd be great. But yeah, it's interesting what people think about the private equity space, the retail space.
Totally agree. Well, this has been awesome. I'm going to put a link in the show description, in the podcast description, to your profile on LinkedIn. I'm going to add a link to the website for Remix Medical. Is there any other? Well, you can send it to me. Any other things that they should be following? Whether it's your other, because I think you've got like Apollo XCM and Azure's and other stuff.
That's our virtual. That's our VMA solution.
Gotcha.
We do that. I think that's been successful for us, because people want to be able to provide a service but not go bankrupt doing it. And and what's funny, just so you know, before we leave, people that we hire for those positions are usually people in hospitality. We don't get healthcare people. We get people that, a lot of people we focus on people who've worked in hospitality industry because they know how to deal with people. So that was kind of one of the things that we wanted to do, is just to make it more, client, patient focused group of people picking up the phones and communicating with the patients.
So you needed the intangibles that they had, and you can give them the experience and the medical terminology and that kind of stuff.
Yeah, that was easy. You can teach someone in a couple of weeks on how to do that, and then just by being in it, they understand. But you can't teach people with medical knowledge necessarily how to be good with people. That's hard. Either you are or you're not. I don't believe that that's something you can train. And so not easily.
No, I agree. You're seeing that. You're seeing that in AI right now. They're like, hey, it's some people are the old day of, hey, learn to code, right? Like, oh, you lost your job as a coal miner or a truck or whatever, learn to code. Well, now with AI, they're like, and now the thing is, learn how to build relationships. Literally, I watched this podcast. Guy said, hey, if you're a paralegal or just a basic accountant or a low-level lawyer or whatever it is, or coder, you may not have a job in 5 to 10 years.
Yeah.
But unless you learn how to be super creative, passionate, and how to build relationships, like that AI can't do.
Yeah.
You better cultivate that, or you will get replaced. You'll make it too easy to be replaced.
Yeah, I mean, you can't. I just think that we're moving to a place where people can't be on an island anymore and be successful. You're going to have to work in some fashion or the other in a team. And I think the thing in the future is going to be in healthcare is going to be, how do we get players that normally aren't used to being on the same court together on the same court, working together in a good way? That's what I think is going to be what's going to happen. That's why I think it's going to be interesting, is to see how people that aren't usually used to working together are going to be able to like coexist in a practice, run a business together, provide healthcare together, and so on.
Exactly.
Yeah.
Well, this was absolutely awesome.
Thank you. Yeah, I enjoyed it.
So I'll include all that stuff in the show notes. If you have any other links for things people can follow, send it over, and we'll make sure to include that. And then this will come out like in the next week or two. This has been awesome.
Great. Thank you. I hope I had a great time, so I hope it works out good.
Oh, I think it will. This was awesome.
Great.
Thank you, sir.
Yeah, thank you. I'll see you online.
Fantastic. Yes, sir. See you on LinkedIn.
Exactly.